make notes, and for sure, share with your team. We are going to be very happy if you can help us to spread the news and share that to all of your team. So for the next couple of weeks, we're going to have double outlet ventricles with Dr. Anderson and Dr. Diane Spicer, and I'm sure this is going to be very interesting. We all are going to learn a lot. 2 days later, 7 p.m. on European time, and we are going to have Dr. Mary Cohen amazingly talking about imaging of ASD. I'm sure this is going to be a great session. We invite everyone to join us today in some hours. We are supporting a very interesting meeting, is the cardiology meeting of Azerbaijan Society of Cardiovascular Surgery. It's called Baku Heart Days. It's going to be on the 22nd and on the 23rd. So this weekend, and we are very happy to have one session dedicated to congenital heart academy, and we are going to talk about hypoplast left heart syndrome. Dr. Anderson is going to talk about morphology. Gil Bernovsky is going to talk about physiology. Sasha Agat is going to talk about surgical repair, and I'm going to talk about post-op care. This is going to be very nice. I hope all of you can join. And on the 27th, we are going to have another a topic about fetal cardiology. Dr. Rima Bader is being very kind to place amazing speakers together to us, and I hope all of you can join. And next month, we have Dr. Silverman's continuing his series. I'm sure this is going to be very good as well. We are supporting the meeting from Sick Kids. It's the Toronto Cardiac Symposium. They are going only to talk about Tetralogy of Fallot. And if you are a surgeon, before this meeting, we are going to have a hands-on virtually. So they are going to use 3D models to teach tips and tricks of the Tetralogy of Fallot repair. I'm sure this is going to be very nice. So if you're a surgeon, if you're interested, just go to this website and subscribe for that. So now with you, we are going to have the meeting of today with Dr. Anderson. I'm sure this is going to be amazing.
Well, good afternoon to you, ladies and gentlemen. So what we are going to be doing this afternoon is we are going to try to understand double outlet right ventricle. And the key to understanding is on the screen in front of you at the moment, because double outlet right ventricle is a ventricular arterial connection. It describes the way the arterial trunks arise from the ventricular mass. Unlike some of the lesions we've been discussing recently, such as transposition, where we can define it as a combination of lesions, this is not the case for double outlet right ventricle. Because what we are going to show you next week is that the ventricular arterial connection can come in various guises. So what our object today is to permit you to understand and to analyze these different forms that we find with this ventricular arterial connection in uniform fashion. So if we are to appreciate the different arrangements, and we will show you these arrangements next week, what we have also to appreciate is that the arrangements themselves represent spectrums. And so when we look at overriding of the aortic root, on the one hand, the aortic root can arise predominantly connected from the left ventricle, whilst the pulmonary trunk and the rest of the aortic root remain connected to the right ventricle. That is not double outlet right ventricle. But when the majority of the aortic root, along with the pulmonary root, arise from the right ventricle, then that is double outlet right ventricle. And when we get to the ultimate part of today's presentation, I'm going to show you how we arbitrate the ends of this particular spectrum. But overriding of the aortic root is but one of the spectrums that we have to consider. We can find overriding of the pulmonary root when it is the aorta that is arising from the right ventricle. And then, as you will appreciate, when the larger part of the pulmonary route arises from the left ventricle, we have transposition. But when the larger part of the pulmonary route, along with the aortic route, have their attachment to the right ventricle, we have that different form of double outlet right ventricle. And then we have the much rarer situation in which both arterial routes override. And you may remember that some time ago now, together with my good friend and colleague Krishna, we discussed this entity, which we decided was best described as double outlet, both ventricles. So those are the spectrums we will be discussing with you next week. And we will distinguish these spectrums from the other form of double outlet right ventricle, in which the interventricular communication is non-committed. So this week, we have to set the scene for understanding. And to do that, I'm going to review for you again cardiac development, because as we have discussed over recent weeks, the embryo does exactly the same thing as the cardiac surgeon during cardiac development, so as to commit one of the arterial routes to the morphologically left ventricle. And so I will revise for you this developmental information. But then I will put the developmental information into the context of what I'm going to call the building blocks of the outflow tracts. And we'll show you how these building blocks differ between what we find in the normal heart and what we find in the setting of double outlet right ventricle. And it is my belief that if we understand these background issues, we can clarify the multiple controversies that have existed through the larger part of my own career. So let's look at cardiac development, and let's put that into the context of controversies. And you will remember, I hope, that at the start of cardiac development, the developing heart shows us double inlet left ventricle, double outlet right ventricle. Hopefully you will remember this image. It's made from one of the interactive PD files prepared by my good friend Wout Lammers and his associate Jill Hickspoors, and you will remember that they work at the University of Maastricht in the Netherlands. So this is showing us the cavity of the human heart midway through the 5th week of development, and it's the stage that we call Carnegie stage 13. So there is the atrioventricular canal, and it is committing all the blood exclusively to the developing ventricle. We see the formation of the starting part of what will become the right ventricle. You know that this is the ballooning that takes place for the right ventricle from the outlet component to the ventricular loop. And at this early stage, developing right ventricle is supporting the entirety of the outflow tract. Now, you will also remember that I showed you the similar situation in an episcopic data set. And this again is a human heart, a little bit later, one stage later, Carnegie stage 14. And I've cut this so that you are looking up at the base of the developing ventricular mass. So there you are seeing the atrioventricular canal. Within the canal, you see the ventricular surface of what we call the atrioventricular endocardial cushions. And hopefully you can appreciate, as I've stated at this early stage, the entirety of the atrioventricular canal is supported by the developing left ventricle. We have, in essence, double inlet left ventricle through a common atrioventricular junction. Now, this is the beginning of the key to understanding, because at this stage, all of the blood that is entering the left ventricle has to pass through the interventricular communication, and we're going to call this the primary interventricular communication, so as to enter the developing right ventricle. As you see, developing right ventricle is supporting the entirety of the outflow tract. Now it follows that the embryo cannot close this primary interventricular foramen. It would be suicide for the embryo to close the only way the blood entering the left ventricle can reach the developing outflow tracts. So a key part of early development, we've discussed this on several occasions now, is expansion of the atrioventricular canal. And it is the expansion of the atrioventricular canal that gives the right ventricle its own inlet. But having expanded the atrioventricular canal, the entirety of the outflow tract remains supported by the right ventricle. So here, during development, we have the prototype of what we can consider as the double outlet ventriculo-arterial connection. So here is a data set showing you that. It's a mouse heart. It's embryonic day 12.5 in the mouse heart. And at this stage, the atrioventricular canal has expanded so that the right atrium has its own inlet. But what I hope you can see is that both the pulmonary root and the aortic root remains supported above the cavity of the right ventricle. So there is double outlet from the right ventricle. You can also see that between the aortic root and pulmonary root, we have two masses of tissue that are coming together, and we call these the outflow cushions. And what I'm going to show you very shortly is that using these outflow cushions, the embryo builds a shelf in the roof of the right ventricle so as to commit the aortic root to the left ventricle. And in doing so, the embryo is using this persisting communication between the ventricles as the outflow tract for what will become the aortic root. And I can show you that by rotating the data set. It's a three-dimensional data set. And I can show you the precise relationship of the aortic root to the developing right ventricle. And there you see that without question at this stage, the aortic root is exclusively supported by the developing right ventricle. And that means the blood from the left ventricle has to pass through the persisting interventricular communication so as to run up through into the systemic pathway. And that means that the secondary interventricular foramen at this stage, remember it is secondary because there has been expansion of the primary foramen to give the right ventricle its own inlet. All the blood going up the aorta has to pass through this secondary interventricular communication. So again, the embryo cannot close the secondary interventricular foramen. And in fact, what the embryo does is to use those proximal outflow cushions. And here you see them. There is the parietal outflow cushion. There's the septal cushion. And they have come together. There is a line of fusion between them. And they have built a shelf in the roof of the right ventricle. The embryo has done what the surgeon does so as to correct double outlet right ventricle. The embryo has created a tunnel so as to connect the aortic root through the secondary interventricular communication with the cavity of the left ventricle. And then the embryo will close the persisting communication between the right ventricle and the aortic root. We're going to call that the tertiary interventricular communication, and that will complete ventricular septation. We can reconstruct the situation in the same heart just to prove to you that the fused proximal cushions commit the aortic root to the left ventricle above the crest of the muscular ventricular septum, and in so doing, part of the cavity of the right ventricle becomes the left ventricular outflow tract. And exactly the same thing happens in the developing human heart. So here I'm taking another of the interactive PD files prepared by Wout Lammers, Jill Hicks-Boers, this time at the end of the 7th week of development, what we call Carnegie stage 20. And there you see the myocardium of the atrioventricular canal. And that is also going to be important in understanding some of the controversies that surround double outlet right ventricle. The right ventricle has its own inlet through the tricuspid valve. The green is the muscular ventricular septum. There are the arterial trunks. But both of the arterial roots, as in the mouse heart I showed you at this stage, are supported above the right ventricle. And here is what happens at Carnegie stage 20, because the embryo, like in the mouse heart, has fused those proximal cushions and has built a shelf so as to commit the aortic root into the left ventricle. And so here, as I did with the mouse data set, I've rotated it a little bit so that you can see the relationship of the aortic root. It is to the right of the ventricular septum. And the embryo, the human embryo, has also used those proximal cushions to build the shelf so as to connect the aortic root with the left ventricle, even though it is aligned with the right ventricle. And it is the membranous septum that completes septation so as to commit the secondary interventricular communication into the left ventricular outflow tract. Here is what it looks like in serial sections. So this is one stage later, or 2 stages later, Carnegie stage 22. The ventricular septation is completed at this stage. Pulmonary root is committed to the right ventricle. And there is the tunnel that the embryo has built. And it's the tubercles of the atrioventricular cushions that produce the membranous part of the septum. But as I say, the inner heart curve is also important because at this early stage of development, the inner heart curve continues to separate the developing aortic valve from the mitral valve. I'm going to call that the inner heart curvature. So this is what it looks like in another mouse heart, the same data set. I've cut it a little bit posteriorly to show you the persisting interventricular communication. Because now the secondary communication has become the outflow tract for the left ventricle. And remember, we cannot close that communication. What the embryo does is to close the communication that persists between the right ventricle and the aortic root. I've called it here an aortoventricular communication. You will call that a ventricular septal defect, and that is the area that is closed by the tubercles of the atrioventricular cushions to form the membranous septum. So let me summarize what I've told you thus far in terms of development. When the embryo closes that tertiary foramen, the aortic root remains aligned with the right ventricle, although connected to the left ventricle. Now, here is a significant point. At this stage, the developing aortic and mitral valves are separated by the inner heart curvature, which is myocardial. And when we get on to our building blocks, I'm going to call that the ventriculo-infundibular fold. But in normal development, if all goes well, if the tubercles of the atrioventricular cushions close that tertiary interventricular foramen, then those proximal cushions will muscularize and they will become the freestanding infundibular sleeve. So this is what we are going to look at happening in the postnatal heart. So let me show you what is going to happen. I've rotated the data set a little bit so that you can see here the aortic roots remain above the cavity of the right ventricle. And there in yellow, you can see the inner heart curvature. And it's interposing between the developing aortic valve and both atrioventricular valves. And this is what happens as those proximal cushions fuse. They form this shelf on the roof of the right ventricle. As you see, the shelf has separated the pulmonary root from the aortic root, and that will become the freestanding myocardial infundibular sleeve. So this sets the scene for understanding the building blocks. Because the inner heart curvature always will separate a developing atrioventricular from a developing arterial valve. Those proximal cushions will muscularize, and in the normal heart, they will form the freestanding subpulmonary infundibulum. But what we are going to show you is that in the abnormal heart, they will become the outlet septum. There are other structures we have to consider, and they are derived from the ventricular trabeculations. And these ventricular trabeculations coalesce and form what we're going to call the septomarginal and the septoparietal trabeculations. So now we're going to look at this situation and see what happens during normal cardiac development when those proximal cushions become the freestanding subpulmonary infundibulum. So if development proceeds normally, that subpulmonary infundibulum will then fuse together with the inner heart curvature, which we're going to call the ventricular infundibular fold, and they will give us the supraventricular crest. What we're going to show you is that that supraventricular crest inserts between the limbs of the structures formed from the trabecular component. The biggest of those is the septomarginal trabeculation. But what you will also see is that the trabecular layer will persist as septoparietal trabeculations and will form the papillary muscles of the tricuspid valve. So now let's look at that in the setting of a normal heart.
Here we're looking at the right ventricular outflow tract of a normal heart. And in the normally formed heart, the fused proximal outflow cushions remodel to become the freestanding subpulmonary infundibular sleeve. And this muscular sleeve lifts the pulmonary valve up off of the right ventricular mass. And this can easily be demonstrated by removing the pulmonary valve and showing you that freestanding muscular sleeve. You can see the extent of that muscular sleeve above the right ventricular mass and anterior to the aortic root. So here's the right coronary artery, and there's the left coronary artery as they exit the aorta. So the freestanding subpulmonary infundibular sleeve will fuse with the inner heart curvature or the ventriculo-infundibular fold during development to form the supraventricular crest. And this area will insert between the limbs of the septomarginal trabeculation or the septal band. And here you can see its cephalic limb extending up to become part of that subpulmonary muscular infundibulum, and the caudal arm, which will extend to join the inner heart curvature. From the cephalic, or I should say the caudal arm, the medial papillary muscle typically arises. So in this area, you can see where that supraventricular crest is nicely inserted between the limbs of the septomarginal trabeculation in the normal heart. And I also should mention that the ventriculo-infundibular fold will separate the atrioventricular from the arterial valve. Many people in the past have thought that there was a small component of varying size in this area that would form a muscular outlet septum between the right and left ventricles. Through dissection, we can show that this is not the case. And here is a long axis echocardiographic simulation looking at the outflow tract of the left ventricle. Here you can see the aortic valve. And in that simulated echocardiographic view, we usually see the outflow tract of the right ventricle. So here we can see the pulmonary valve and that freestanding muscular infundibulum. There is an evident fibrofatty plane that extends between the aortic root and the left ventricular outflow tract and the subpulmonary muscular infundibulum. So that this shows us nicely that there's no potential for a muscular outlet septum between the right and left ventricles. I have another dissection that will also show us a similar thing. So here I've removed the free wall of the right atrium, right ventricle, and pulmonary trunk, as well as dissected away a portion of the aortic root, which contained the right coronary aortic valvar sinus and valve leaflet. So here is the freestanding muscular infundibulum that allows the pulmonary valve to be lifted up off of the right ventricular mass. You can see where it joins the inner heart curvature and forms the supraventricular crest. That inserts nicely between the limbs of the septomarginal trabeculation. So there's the cephalic limb, and here's the caudal limb, which gives rise to the medial papillary muscle. This is the body of the septal band or the septomarginal trabeculation. There is a nice fiber fatty plane between the aortic root, the subpulmonary infundibulum, and the aortic root and the inner heart curvature, so that there is no potential for a muscular outlet septum between the normally developed right and left ventricles. This is the tricuspid valve, and you can see nicely where it crosses the membranous septum, and we can see the interventricular component and the atrioventricular component.
So if we are now to look at these building blocks in an abnormal setting, and this is what happens when we have the ventricular arterial connection of double outlet right ventricle, we see that inner heart curvature, or the ventricular infundibular fold. It interposes between an atrioventricular valve and an arterial valve, but it can be myocardial or it can be fibrous. You've seen that in normal development, those proximal cushions become the freestanding muscular subpulmonary infundibulum. In the abnormal situation, they persist as the outlet septum, but it too, in most instances, is myocardial, but it can be fibrous. The trabecular layer, however, persists where you saw it in a normal heart as either the septomarginal trabeculation reinforcing the surface of the septum, or as septoparietal trabeculations, and also forming the papillary muscles of the tricuspid valve. So now let's look at where we find these building blocks in the setting of a classical example of double outlet right ventricle. And here are the building blocks that you're going to see. I'm showing you the situation in which we have a subaortic interventricular communication. What are the building blocks? The outlet septum. It is the outlet septum because it interposes between the outflow tracts. The major structure derived from the trabecular layer is the septomarginal trabeculation. What you're going to see is that it reinforces the septal surface. And there, shown to you in green, interposing between the leaflets, an atrioventricular valve, an arterial valve, we have the ventricular infundibular fold. I've shown you the situation here with a subaortic defect. That now is what Diane is going to show you in a heart with double outlet right ventricle.
This specimen is a cardiac explant, and you'll see that the free wall of the remaining portion of the right atrium, right ventricle, and arterial trunks has been resected. This shows us nicely that the ventricular arterial connection is one of a double outlet from this morphologically right ventricle, and that both the aortic valve and the pulmonary valve are supported by complete muscular infundibulums. This specimen shows us nicely how some of the building blocks have come apart, and the proximal outflow cushions have not formed normally, allowing for this prominent outlet septum, which is now exclusively a right ventricular structure and serves to separate the two outflow tracts. The septomarginal trabeculation also is a bit hypoplastic in this case, so that its body is not typically as large as it usually is and is much more apical. The caudal arm rises up to join the ventricular infundibular fold, or the inner heart curvature. And here we can see the ventricular infundibular fold separating our atrioventricular from our arterial valve. The cephalic arm extends up to join the outlet septum. The interventricular communication is an outlet defect because it lies within the limbs of the septomarginal trabeculation. The subaortic infundibulum also prohibits any possibility of the aortic valve to be in fibrous continuity with the mitral valve, which lies within the inlet of the left ventricle. It is arguable that this interventricular communication may be non-committed, but the easiest route to an outflow tract would be to the subaortic outlet. So this would be an easy matter for the surgeon to create a tunnel from the interventricular communication to the subaortic infundibulum and place the aorta back into the left ventricle and restore the pattern of circulation. It's important to remember that the patch in those cases without a subaortic infundibulum would be a much shorter patch in order to tunnel the aorta back into the left ventricle.
So now you know how we have double outlet right ventricle on the basis of development. You've seen what happens to the building blocks during normal development and during abnormal development. So how can we put all of this together to resolve those old controversies? Well, I've already told you that inner heart curvature can persist as a myocardial structure, but it can become fibrous even when both arterial trunks are supported by the morphologically right ventricle. Now, one of the oldest of these controversies was that you had to have bilateral conuses in order to have double outlet right ventricle. But we now know that is not the case because the inner heart curvature can be fibrous even though both arterial roots are supported by the right ventricle. To prove that, Diane's now going to show you a very nice example of double outlet right ventricle with, or rather without, bilateral infiltration.
In this specimen, the free wall of the arterial trunks, the right ventricle and the right atrium, have been removed. So we're looking at the septal surface of the right ventricle. Here is the tricuspid valve. You can see that there is a double outlet to this right ventricle where the majority of the aorta is committed to this right ventricle, along with the entire pulmonary trunk arising from the right ventricle. So there is no pulmonary stenosis in this case. The outlet septum now is a prominent right ventricular structure that separates our pulmonary and aortic outflow tracts. You can see the pulmonary valve was supported by a complete muscular infundibulum. There is a subaortic interventricular communication, and it extends to become perimembranous. There is a fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior aspect. As well, we see that there is fibrous continuity between the aortic valve and the mitral valve within the left ventricle. This is the inner heart curvature, which separates our atrioventricular from our arterial valve.
Now that issue of the infundibulums and whether we have to have bilateral conuses takes us to the second of the old controversies. Can we have Tetralogy of Fallot with double outlet right ventricle? And here we have to go back to the fact that double outlet right ventricle itself is a ventricular arterial connection. It is not a specific phenotype. And we know that Tetralogy of Fallot can indeed coexist with the ventricular arterial connection of double outlet right ventricle. So now we're going to look at a very nice example showing you Tetralogy of Fallot coexisting situation of both arterial roots arising from the right ventricle, but with the phenotypic anatomy of tetralogy.
Here we're looking at the outlet of a morphologically right ventricle, and the ventriculo-arterial connection is showing us one of a double outlet from the right ventricle, so that the greater part of this aortic root is supported within the right ventricle. This specimen also shows us the phenotypic features of Tetralogy of Fallot. So here is our prominent outlet septum, which is now a right ventricular structure and is deviated in anterior cephalic direction, yielding subpulmonary infundibular stenosis. There's also an interventricular communication that is lying within the limbs of the septomarginal trabeculation. There's the cephalic arm and the caudal arm, which extends to connect with the ventriculo-infundibular fold and will protect the conduction axis along the posterior inferior border. The ventriculo-infundibular fold separates our atrioventricular from our arterial valve. This specimen also shows us fibrous continuity between the aortic valve and the mitral valve within the outlet of the left ventricle, and shows us that there is no need to have bilateral muscular infundibulums supporting both of the arterial trunks as they arise from the right ventricle. As well, a double outlet from the right ventricle can exist when we have the phenotypic features of Tetralogy of Fallot.
So those are the old controversies. And I think you've seen enough now to show you that you don't have to have bilateral conuses in order to have double outlet right ventricle, but the Tetralogy of Fallot certainly can coexist with the ventricular arterial connection of double outlet right ventricle. But there is an ongoing controversy, and that is the nature of the interventricular communication and whether we should call that a ventricular septal defect. Well, for sure, it is a communication between the ventricles. I've shown you, however, that it is the secondary embryonic interventricular communication. And by now, you should have realized that you cannot close that secondary embryonic interventricular communication. And you've seen, in fact, that it is never closed during normal development. Instead, it becomes the outflow tract for the left ventricle. And that is what the surgeon does in correcting double outlet right ventricle, when the surgeon creates a shelf in the right ventricle so as to tunnel one or other of the arterial routes through that secondary interventricular communication to the left ventricle. So, irrespective of what we're going to call it, that secondary interventricular communication remains the outflow tract for the left ventricle. The key point, it cannot be closed. So let me remind you again, here is that mouse heart, the developing right ventricle supporting the aortic root. There is the secondary interventricular communication. And you see that I've shown it with a double-headed green arrow because the green cannot be closed. So there is the area for ventricular septation. And irrespective of how much of the aortic root is supported by the left ventricle, it is that area shown to you by the double-headed red arrow that will always be closed by the surgeon. So if in the setting of Tetralogy of Fallot with concordant ventricular arterial connections, that double-headed red arrow is called the ventricular septal defect, why should it not also be called the ventricular septal defect when we have double outlet from the right ventricle?
This specimen has a double outlet right ventricle and has been surgically repaired. It's also been cut in a roughly 4-chamber plane, and we're looking at it from posterior to anterior. So here's the tip of the right atrial appendage, the hypertrophied right ventricle, left atrium, a portion of the mitral valve, and left ventricle. You'll also note that the muscular interventricular septum is quite hypertrophied. If I place my probe from the crest of the muscular ventricular septum across the aortic root, you can clearly appreciate that the majority of this aorta is committed to the right ventricle. This specimen also had the phenotypic features of Tetralogy of Fallot, and it's important to remember that you can have those phenotypic features coexisting with a double outlet ventriculo-arterial connection. We all know that the typical phenotypic features of Tetralogy of Fallot show us concordant ventriculo-arterial connections with much less of an aortic override of the interventricular septum than in this specimen. It's important to remember that the plane of septation, or where the surgeon places his patch, restores normal circulatory patterns. And in those hearts with double outlet right ventricle, this patch is placed in a much more perpendicular plane relative to the crest of the interventricular septum, secondary to the severe degree of aortic override. This patch placement effectively tunnels the aorta back into communication with the left ventricular outflow tract and allowing for normal circulation to resume. Those hearts that have less aortic override or the typical features of Tetralogy of Fallot have the patch placed in a much more parallel plane with reference to the interventricular septum. Both patches are placed to close the ventricular septal defect.
So we've been through the controversies. There is one more we have to consider, and that is how we divide the spectrums of amalgamation that we're going to be considering with you next week. And now we know that this is best done by assessing the short axis of the overriding root, not the long axis. And here we can take advantage of developing technology because we can now see that with precision using three-dimensional techniques for imaging. And here is an exquisite computed tomogram prepared by my good friend Tony Barczek. I've told you before that Tony works at Medical University of South Carolina in Charleston, and he prepared this image for me quite some time ago, but it does not lose its potency, because what you see is how the cord of the ventricular septum relates to the overriding aortic root. And now with precision, you can determine how much of this overriding root is connected to the left ventricle and how much is connected to the right ventricle. And in this particular situation, it's about half and half. So we're going to give the aortic root to the left ventricle, and we describe this as concordant ventricular arterial connections. But in this way, with precision, we can determine precisely when the larger part of the overriding root becomes committed to the right ventricle, along with the other root, telling us that then we effectively have double outlet right ventricle. So here, concordant, a little bit more of overriding, and then we'd have double outlet right ventricle. So what we have tried to do today is to provide you with the understanding to appreciate the different spectrums that we're going to show you next week. And that is because double outlet right ventricle is a ventricular arterial connection. It is not a specific phenotype. The phenotypes permit you to describe the different spectrums. And what we're going to look at next week is how the important feature is the location of the interventricular communication. It's always an outlet defect, but the key will be whether that interventricular communication is committed to the aortic root, pulmonary root, to both roots, or rarely to none of the roots directly. And what we're going to show you is that other features are important. Obviously, they will need to be recognized and described, and that is what we're all going to share with you next week, but hopefully on the basis that now you understand basic features of double outlet right ventricle.
It was great, and I can't wait for next week. I think it's going to be an awesome session as well. So as usual, I would like to ask Dr. Silverman to make his initial comments about today's presentation.
I can't seem to start my video. If you could start my video for me, I'd be happy. But if you don't want to see me, that's also fine. I thought this was a very interesting session because of the description of the inner heart curvature. I think that it's much more extensive in its just showing with the green line of the Lama's models, that it's really quite extensive. And the other thing that looking at this for the point of view is that I thought that you described very beautifully the development of the outlet septum, and where that is also part of the proximal cushions within the outflow tract. So from the point of view of looking at this from a novice, that was very beautifully defined the various sections of the embryology that persist in double outlet right ventricle. And I've always thought that double outlet right ventricle as a failure of all of those normal things coming together. So Bob, maybe you can make a comment. And Diane, I must compliment you on your beautiful description of the various parts of the outlet of the right ventricle that persist in double outlet.
Well, Norman, I think you've already said everything that needs to be said. I agree with you 100%. I thought the demonstrations that Diane did for us this week, particularly the demonstration she did of the normal heart, I thought that was quite exquisite. And the way she made the slice just below the leaflets of the pulmonary valve and lifted it away.
Yes.
And then folded the wall back to show you the freestanding subpulmonary infundibulum. I mean, that is where pictures are worth thousands of words. That was absolutely exquisite. And it does make the point, as you have said, because in normal development, the proximal cushions muscularize, and then they become the freestanding muscular subpulmonary infundibulum because the core of those cushions disappears. And that's what becomes the plane, and in fact, in the subsequent images that Diane showed, where she'd cut sections across those two hearts, you could see that fibrofatty tissue that was interposing between the infundibular sleeve and the aortic root. And during development, that is the core of those outflow cushions. So if the development does not proceed normally, and if the embryo is unable to close the tertiary interventricular communication, then those proximal cushions retain their position in the right ventricle. They're no longer able to separate so as to produce that external plane between the pulmonary root and the aortic root. So you have a persisting interventricular communication, and then the muscle mass persists as the muscular outlet septum, but it does not always muscularize. And that's why on occasion, it's a fibrous outlet septum. And we'll look at that next week when we show the variations in the setting of double outlet right ventricle.
Sure, and I always look at things, and many people who have not the opportunity to look at specimens are looking at echocardiograms and trying to define morphology. And of course, the issue about the 50-50 rule is very, very important, as you've shown from the cross-section. I know you haven't shown the other areas that Lovacek has so beautifully defined of how you can see the outlet septum moving. But as an echocardiographer, the description is, of course, that we know that there's a similarity between tetralogy and double outlet. Of course, if there's no pulmonary stenosis, it's much easier to say, aha, it's double outlet right ventricle. But when there is pulmonary stenosis and superior deviation of that outlet septum, Then the echocardiographers and many of the opposing philosophies of double outlet come into play as to whether there is mitral aortic fibrous continuity. And as an echocardiographer, we have to recognize that it is very difficult to tell the difference between fibrous tissue and muscular tissue. And that's where the controversy exists in the minds of echocardiographers. If, for example, they can see the non-coronary or the non-facing sinus with its leaflet in fibrous continuity or directly hinging with the with the mitral anterior leaflet, they call that Tetralogy of Fallot. And if they can't see that, they call that double outlet. And of course, I think this is the essence of the echocardiographic controversy. I think, as you've shown, that you can have an aorta way over from the right ventricle and still have fibrous continuity. And that, of course, is still double outlet right ventricle with all of the building blocks. And Bob, I know that you have a great way of articulating my feeble attempts to describe this. So let me have you once again emphasize those points.
Well, you again, Norman, you have said it. And it's what I tried to emphasize during today's presentation. Once more, I think you hit the nail on the head, because Diane in her specimens showed you exquisitely. The image she showed of the tetralogy, which happened to have a posterior inferior muscular rim, had probably 80% of the aortic root arising from the right ventricle. So unequivocally, that was a double outlet ventricular arterial connection. And in a way, these old controversies are now clouding the understanding. And I think that's what we're trying to do today. We're trying to take away these old controversies because they don't help us to understand double outlet right ventricle. And they don't help us to understand Tetralogy of Fallot. And the other key point you've made was that irrespective of how much of that aorta arises from the right or the left ventricle, the surgeon always puts the patch in the same place. And that is why it is the area that is closed by the patch that we should be calling the ventricular septal defect. The embryo can't close the secondary interventricular communication. Everybody knows that the hole that currently most of the people call the ventricular septal defect in double outlet can't be closed. And that's because it isn't the ventricular septal defect in the same sense that it is in Tetralogy of Fallot. So if we could wipe out all those old controversies, if we could start with a clean sheet, a tabula rasa, we could understand it from first principles. But unfortunately, we are burdened by these old controversies. And the young people who are watching today, those are perhaps who have seen this for the first time, will think, well, what on earth is all the fuss about? Because it should be so easy to understand. And in many ways, we are continuing to confuse people when we bring up these old controversies. As you say, the echocardiographer often cannot distinguish between an area of fibrous separation and an area of muscular separation. And does it really matter? I put that back to you. Does it really matter whether it's fibrous or muscular?
Well, the only issue, of course, that matters is that when you repair a double outlet, the surgical complexity is slated to be more than that in tetralogy. So you can charge more if you're a surgeon.
Well, so that was also the point that I think that Diane made very beautifully when she showed that last specimen, the one that she showed from behind where there was the patch. And there is no question that the patch itself has to be longer when you have double outlet right ventricle, but that is irrespective of whether you have a bilateral infundibulum or whether you have fibrous continuity between the leaflets of the aortic and mitral valve. Even if there is fibrous continuity, the patch will be much longer because it is creating a tunnel so as to put the aortic root back into the left ventricle.
Sure. I think also we ought to emphasize the point that the controversy is only for the subaortic form of the defect.
Well, not strictly. No, that's not strictly true, because we also have the problem of the Tausig-Bing spectrum. And you will remember there is equal controversy. Some argue that we should only describe the Tausig-Bing malformation with bilateral conuses, because there were bilateral conuses in the original heart described by Dr. Tausig and Dr. Bing. To me also, that is a non-controversy, because we'll show you next week that you can have Tausig-Bing hearts with fibrous continuity between the mitral and the pulmonary valve, when the pulmonary route now is predominantly arising from the right ventricle along with the aortic route.
Yes, I'm sorry, I should have mentioned that, because I put it in the app anyway. So
there you go. If it's in the app, it has to be true.
That's true. Seeing you vetted all of the pictures. Now, one issue, of course, we have some young surgeons who are looking at this, and what we haven't seen is a simulation of what the surgeon sees. We see exposure that is quite beyond what the poor surgeons have to do when they repair these defects. And I came across this in a surgical book, because really what the surgeon looks at, he looks at the area where the membranous closure of the septum is, and he just simply puts the patch in the appropriate place. And so they all look pretty similar to the surgeon.
Indeed. And I mean, when Diane shows us the hearts next week, she hasn't made the demonstrations yet for next week, but perhaps when she's making the videos for next week, we can ask her to run the probe around the area where the surgeon will need to place the patch so as to put the arterial route back into the left ventricle. And she will be emphasizing next week the key to the posterior inferior border, because that's where we're going to see the conduction axis.
Correct. I mean, that was very beautifully shown on this specimen with the posterior muscular rim. Because if there's no posterior muscular rim, then of course there's a perimembranous extension of this outlet defect. And of course, then the surgeon needs to be contacted to say, well, beware, not that the surgeons need that information, but certainly it gives them peace of mind when they have that before they even open the heart.
Well, I'm sure they feel more comfortable if you remind them of that, Norman. If you say, but you need to be careful because this one has a perimembranous defect, correct, or this one has a muscular posterior inferior rim.
Yeah, and we can see that echocardiographically, and we can also see that when there is a perimembranous extension, that the tricuspid and the mitral valves run on the same level. And so that becomes, when on the inlet part of a four-chamber view, so that becomes an easy point to make for the surgeons. And as an echocardiographer, when you do that, you develop the surgeon's trust, and the trust between a surgeon and an echocardiographer in the operating room is very, very important. So the surgeon knows what the echocardiographer can give him, and the echocardiographer knows that he's given the information to the surgeon, and he will do an appropriate operation. And watch out for the conducting tissue.
My good friend Jagannath, who is a regular visitor to us, has asked an important question here that I note, that he says oftentimes we don't show the view as he sees it in the operating room, and it is difficult to manipulate the specimens to show as he would see it in the operating room. He's suggesting we might look through the tricuspid valve, but it's very difficult for us to do that. So we can't answer all of the questions, sadly.
Yeah, and you realize how difficult the surgical
he goes on to say that he's made a second one here. He says because he recognized that Diane's cuts are echoing the echoes, and as a surgeon he can relate very well, but Jagannath knows what he's talking about. So if it's okay with Jagannath, we're in good shape.
Yeah, great.
have actually a lot of good questions today. I'm very happy for that. Thank you guys for all of your questions today. We have one question from Dr. Vera Aiello from Brazil. She says, thank you, Professor Anderson, for the outstanding presentation. And I need to say the same because it was very nice. Thank you. Which clarifying the principles for the understanding of DORV. I have a question not directly related to the double outlet, but to the nomenclature of the normal heart. I know that you have been recently working on the next version of the new terminology anatomica, and I would like to know if there is a clear definition of what we call the aortic and pulmonary routes. What are the involved structure in such a route?
That's a very good question, and it's something that really we need to, we're reaching the end of the series of presentations that we've done in this academic year. And Diane is getting very tired, and she's been working very hard, and she's been working over and above the call of duty to prepare all these videos. So she needs a little rest, but we're going to try to prepare we're going to try to start again. We're going in September. We have some more sessions planned for June, but then we're going to take a little break. But the point that Vera has made, I think, is very important, because I think we should start off our series of presentations for next year by going back to the normal heart and answering the sort of questions that Vera is now answering. So Diane, for next year, will make sure we make presentations to answer that and other questions. But I can tell you that the aortic root or the pulmonary route now, we didn't define it for Terminologia Anatomica, but we have defined it for other reasons. And we've been working with Justin Tretter and Shumpei Mori to do this. And we know that the aortic route extends from the virtual basal ring, which is what echocardiographers call the annulus, and Norman knows all about this. So the virtual basal ring is the plane you create by joining together the nadirs of attachment to the valvar leaflets. And so that is the proximal extent of the arterial route, and it extends to the sinutubular junction. Now, the key point here is that the aortic route or the pulmonary route or the arterial route, as then thus defined, is not the same as the outflow tract, because there is then part of the outflow tract that is below the arterial route. So if you think of it in the setting of the pulmonary route starts at the level of what Norman, you as an echocardiographer would call the annulus. So below the annulus, you have the infundibulum, and the infundibulum is separate from the pulmonary route, even though there are extensions of the myocardium that go into the pulmonary route, and we find them at the bases of the valvar sinuses. But these are the sort of things that we need to get into. It's a very good point that Vera has made. If we have the stamina to come back and get going, if Diane has the stamina, we'll do this and we'll prepare this. And our first presentations for next year's schedule, we will devote to normal anatomy. And Grace, maybe you'd like to say something about this.
It's going to be amazing. I'm sure we are going to have a good series, and we all need this break. And so probably July and August, we are not going to have Dr. Anderson sessions. And again, thank you, Diane, for the amazing specimens that you're bringing to us. These videos are really contributing to the understanding of everybody. Thank you very much. And for sure, I think it's a very good idea to start with nomenclature next year. You're going to.
I should add one thing, Grace, and that is we are going to have some more during July. And in fact, Vera, who asked that question, has already prepared a beautiful video that I've already seen on that rare lesion of concordant ventricular arterial connections with parallel trunks. So we shall be using one of Vera's presentations before we finish this year's sessions. So we do have some more to keep us going for a little bit longer during June, but then we're going to need our break because we need to recharge our batteries. And Norman will be happy because he doesn't have to get up at 5 o'clock in the morning.
We really
Sure.
wake up very early, and we are very happy for that because you make all the difference on this session. And I will be very, very proud of Dr. Vera's presentation. I think all of you know that she was my teacher when I was a fellow, and she's just amazing. We have more questions now. I have another question from Brazil. Dr. Paulo Zielinski is asking, just to make it straight, following the point raised by Norman, from the nomenclature point of view, in an echocardiography report, what would be the best description? Tetralogy of Fallot with DORV as a type of a VA connection, or DORV coexisting with Tetralogy of Fallot? Or it doesn't matter how it describes, since they are the same thing?
Norman.
Well, I think they are the same thing, but as Bobbert made this point before, is we're describing a ventricular arterial connection in double outlet. What we describe in tetralogy is a phenotypic expression, and so the two of them can coexist. I don't know whether Paulo has a problem with this, but I think if you've been in the Anderson School long enough, you don't have a problem with this, because we know that the two of them can coexist, and I've resolved that in my own mind. You can get tetralogy of Fallot with the extreme override. That's double outlet.
But what we mean is that, how do you describe, when you report a lesion like that, do you say this is a DORV with Tetralogy of Fallot, or you say this is a Tetralogy of Fallot with DORV, or it doesn't matter?
Can I come in here? Because I think the starting point of today's discussion is the double outlet is not an entity in itself. It is not a phenotype. So in my opinion, the phenotype should come first. So I think we should have Tetralogy of Fallot with concordant ventricular arterial connections, or Tetralogy of Fallot with double outlet connection. Just as for me, I would say it's the Tausig-Bing malformation with double outlet, or it's the Tausig-Bing malformation with transposition, or in the cases we discussed with Krishna, we have double outlet both ventricles with double outlet connection or with concordant or discordant connection. So I think the phenotype should come first, and double outlet is not a phenotype in itself. And that's another of the ongoing, not controversies, but the ongoing mistakes, that people think of double outlet as a phenotype. It isn't. It's a combination of phenotypes.
Perfect. Makes all sense.
Absolutely. Thank you, Bob. Of course, in the Van Prague nomenclature, which we sort of not talked about, there is no tetralogy of Fallot in the description that you have just so elegantly described. You know, it's either normally related great vessels, concordance, discordance, etc., but no tetralogy in that group.
Indeed. Well, that's of course because Richard didn't accept, initially did not accept tetralogy as existing with double outlet, because irrespective of the extent of override, he simply called it tetralogy. So in many ways, tetralogy was a thing of its own, but you make a good point. I'm looking through the questions, Grace, and I know that I noticed that we've had another one from Carl Ostrakonis, who is another of our regular questioners. And he says, does the position of the VSD guide how to approach the way to close it? And absolutely, that is the case. And that is why geography is also important. I mean, we've been concentrating, and our concentration is on the borders, but for sure, the location of the defect will be important, and the interventricular communication is not the VSD, but the interventricular communication being an outlet defect will be quite different from when the interventricular communication is opening to the inlets, and that will direct the surgeon how best to approach it.
And there's one question. I don't know if you're going to cover this next week. They're asking you to explain the DORV with straddling AV valves.
Well, the straddling AV valves, we discussed that in our previous sections, and we have to appreciate that the things coexist. And so when we have the straddling AV valve, if it's straddling tricuspid valve, it is incomplete expansion of the atrioventricular canal. If it's straddling mitral valve, it's extreme expansion of the atrioventricular canal in combination with double outlet right ventricle. So you have to put the things together to get the final answer.
May I make one further point for you, Bob? And it's your point that, and maybe Paolo should direct himself to reading the original literature of Fallot, because in Fallot's original papers, one of the patients clearly had double outlet right ventricle that he described as tetralogy. He described it as lamellar blur. But
Indeed.
I mean, so I think that this has been with us for a long, long time.
And as we all know, Fallot himself called it the communication interventricular. It's only we Anglo-Saxons who introduced this terrible term, the ventricular septal defect. Diane, do you have any more comments to make? Do you want to say any more about your exquisite dissect? The final one you did showing us, the one with the patch, you did a great job with that. So thank you for that.
Well, I just have to say that all of the embryologic knowledge, no matter whether it's with a normal heart or with the congenitally malformed hearts, has really helped me to better dissect these specimens and describe them. So I thank you for that.
Well, I think it's the way it's all coming together and the way you are able to take the information that we provide and then you can turn it into showing the specimens. I think it's spectacular. And I think that the combination of what we're doing has been so important over the past year. And hopefully we can continue that.
I'm glad to participate with you.
I think Diane is sort of in your head, Bob. She knows everything that you've said, and she's able to then translate that into her specimens in a way that we were not able to do in the old days at the Brompton Hospital when I worked with you. I think that the new dissections have really add an incredible amount to understanding.
Indeed, I agree with you 100% there. And the ability that we now have to make these video clips and incorporate them and put them along with the didactic information makes it so much easier to understand.
I think maybe many members of the audience don't appreciate that Diane makes these specimens without having actually heard your descriptions. And that it's so amazing that she's in your head so much that she can get exactly the points that you want to make put across in the specimens.
Norman, I think that goes with nearly 40 years of association.
Yeah, the hammering of those points into your heads, right? I understand that personally.
And the good news is we had Diane from the outset, so we didn't have to worry about the old controversies.
That's correct. Well, it's been a great session.
Grace, before we go, we should tell everybody that tomorrow is Diane's birthday. So
Yes,
we all take this opportunity to wish Diane many happy returns tomorrow. We hope she has a great day tomorrow, and we hope you get on the golf course, Diane, and have a great time.
Thank you.
Enjoy your day.
Yeah, great. Many happy returns and in health, Diane. That's the most important thing. Be healthy.
Thank you.
Guys,
Bye.
thank you very much. It was, as usual, an amazing session. And happy birthday again, Diane. And thank you again for all that you've been doing for Congenital Heart Academy. We really appreciate that. And guys, see you later for Mary Cohen webinar about ASDs.
We'll be back. Thank you.
Bye-bye, guys.
Bye.